to give you guys a little background on Dr. Khalaf, he's a triple board certified in internal medicine, cardiovascular disease, and interventional cardiology. As an interventionalist, he has extensive knowledge in the latest technology involving peripheral artery disease, structural, and percutaneous coronary interventions. To get started, the simple question, what is PAD?
PAD, Shannon, stands for Peripheral Arterial Disease, which is the same thing as PVD, which is Peripheral Vascular Disease. And in medicine, we love to confuse people and use two different acronyms to describe the same disease process. But essentially, what it is, it's blockage or atherosclerosis in any of the arteries outside of two areas. The heart, because that has its own name known as coronary artery disease, and the brain, which has its own terminology known as cerebrovascular disease.
So just a takeaway point here, PAD and PVD, same condition. I know that this is a point of confusion in nursing school. It was for me at least. So just remember that. And in terms of how primary care docs should approach assessing patients for PAD, what signs should they be looking for?
Yeah, in medicine, Shannon, you know, we've sort of been programmed to be symptom driven, which is the same way of saying, don't go looking for problems in your patients unless your patients present to you a symptom or a problem. And usually that symptom would be pain in their legs, especially with ambulation or walking. This is known as claudication. And I want everyone to think of claudication as if you're going to the gym and you are just killing yourself and just lifting more than you can handle. And whenever your muscles release lactic acid and they burn and they cramp, that's your body's way of telling you, hey, you are creating more of a demand for me than you are giving me a supply of oxygen. And the same concept happens in the legs. In the legs, it's the large muscle groups that tend to trigger and tell us there's something going on. And it's usually in the calves and or the hamstrings if you're dealing with a blockage that's higher up. And again, walking, making it worse, and the pain getting better with rest is sort of that main factor that the primary care physicians should be looking out for, cardiologists, vascular surgeons, things like that.
Right, and I know that is something that we see with patients a lot when they're walking around, a lot of pain. As soon as they rest, that pain starts to dwindle down a bit.
Yeah. I will add this caveat too, though, Shannon. Everyone should realize that PVD is one of those things that it tends to creep up on you. And what do I mean by that? I mean that you can have a tremendous amount of blockage in your legs and not complain that much. For example, I have a lady with a completely occluded aorta. I mean, literally her aorta right before the iliac bifurcation is blocked completely. Her toe, she goes and gets her toes done. Her toes look fine. She has no wounds anywhere. She walks. And I've been sort of encouraging her to get this fixed. But she says, I don't have any problems. Why should I get it fixed? And I can't argue with that. And so it's one of those disease processes where people should understand that some people respond quickly to blockage and some people it's profound blockage and they do just fine. But we find ourselves in a position where if patients are dealing with a big degree of blockage and if left untreated, it can lead to gangrene, amputations, toes removed, feet removed. And it's a problem, and it's so sad because it could have been prevented if it was just caught early. So that's why I'm a big proponent of screening for vascular disease in patients that carry a lot of risk factors for it.
And that leads me to my next question. Who are those patient populations at risk for PAD?
It's the same patients that have the risk factors for coronary disease, which is much widely known. Smoking is a huge one, especially for vascular disease, diabetes, hypertension, family history, hyperlipidemia, sedentary lifestyle, things like that, things that we know contribute. I also notice peripheral vascular disease is extremely common in patients on dialysis and those with renal failure. That's a huge risk factor for PVD.
And do you think that you could dive a little bit more into the relationship between coronary artery disease and PAD?
Yeah, for sure. So I always tell my patients whenever I'm screening them for PVD, and especially those that have had heart attacks, I say, atherosclerosis is a disease process that does not discriminate, meaning the same pathological process that led to blockage formation in your heart could easily lead to the same process in your legs. So they do tend to go hand in hand, but it's also surprising that just because you have one doesn't necessarily mean that you have the other, but it should raise eyebrows and make people, be more conscious of it and definitely screen for it.
And what can be confused for PAD? Other conditions that people think they have it and don't, or vice versa?
Two major ones come to mind: spinal stenosis or anything related to the back, neurological pain, sciatica, shooting pains down their legs, usually in the back of the legs and the buttocks. That's a big one. That ends up being a really big one. The other thing that can lead to a lot of discomfort, pain, and usually swelling legs is venous disease, which I also do, superficial venous disease and deep venous system disease. And so that's more of a vascular etiology as opposed to the spinal stenosis and neuropathic, which is a neurological condition. But it definitely can confuse patients and physicians, by the way.
Mm-hmm. And who should one see to get tested? Primary care doc, cardiologist, what would you recommend?
The primary care docs, the way the medical system is set up here, and I agree with, they tend to be the quarterbacks. They have good relationships with their patients, and any symptoms should warrant referral to a specialist. But I would encourage everybody to empower themselves, and if there's a certain condition that you or your primary care doctor is concerned about, such as PAD, in today's world, it's very easy to figure out who's treating PAD, with the practices promoting their physicians and the internet and Google searches and whatnot. So I would encourage people, in an effort to minimize, instead of bouncing around from physician to physician until you can eventually, see the person that can intervene on you, is to try and find that person that can intervene. But PCPs, interventional cardiologists, vascular surgeons are traditionally those doctors who can fix these types of blockages and help these patients.
And say, a patient presents with the symptoms that we discussed earlier, what types of tests would you perform to test for PAD?
Starting with the least invasive and moving up to the most, the ankle brachial index, or ABI, which is something that you hear often. And all that is a fancy way of saying check the blood pressure in the ankle and compare it to the blood pressure in your arm. And so what we're looking for is a ratio. And usually the ratio should be 1, if not higher. So anything less than sort of 0.9 should raise eyebrows. Anything less than 0.8 is almost diagnostic for peripheral vascular disease. I traditionally don't start off with ABIs because I like to get what's called an arterial Doppler. And so that's an ultrasound, which also includes an ABI as part of the test, but it also allows us to see within the artery and check the waveforms and check the pressures to see if it's multiphasic, biphasic, or monophasic. And it sort of gives us an idea of how strong that pulse is and provides us with a lot of information because it can sort of point to where the blockage actually is. And then the most invasive test, Shannon, is a CT angiogram in terms of diagnostic tools, which is just a CAT scan, but we have to inject the patients with contrast so we can light up the inside of those arteries. And that sort of gives you a definitive roadmap, if you will. And it also helps us plan out our interventions. I like to do a lot of pedal access where I come in through the foot, and it's really nice to know if those arteries are open or not. And sometimes the ultrasound, it doesn't really give me all the data that I need to make that judgment call.
And so at what point would you perform a CT angio and recommend that test when you have a good sense of this patient might have PAD?
Yeah, so I always usually start with the arterial Doppler, that ultrasound. And then sometimes in my mind, I'm like, well, a CT angio is unnecessary. Like the Doppler gave me all the information I need. Why would I subject the patient to an extra test, extra radiation, extra contrast, extra bill for their insurance? It doesn't make sense. And so a lot of times I skip the CT angiogram, but it just sort of depends on the arterial Doppler. If there's something confusing or more information that I'd like to know, then I do get a CT angiogram to help me. But usually in my particular practice, I use the arterial Doppler because it's a cheaper test and it gives me the information that I need to determine what the next best step is. And so if it's positive, then I'll jump straight to intervention.
Mm-hmm. Yeah, and we just had a question come in from the audience asking if you would start immediately with invasive treatment or opt for medical treatment. Could you speak a little bit to that?
Yeah, no, so that's a good question. So I had to argue with an insurance company not too long ago on a peer-to-peer about a patient who had a 100% blockage in their leg. And I knew it was occluded because you could see it on the Doppler. Mm-hmm. And the peer-to-peer, and I use peer in quotations because I don't believe this person actually does these types of interventions. He was telling me, oh, well, this patient hasn't done optimal medical therapy. So I asked him, well, what is optimal medical therapy? I said, this patient's on aspirin, Plavix, a statin, cholesterol-lowering medication. So, oh, well, you haven't tried Pletol or Calistazole. And I said, well, this medicine that you're referring to is not class 1 in the guidelines, meaning class 1 means you really, really should use this medication. And so, it can encourage the increased formation of collateral flow. And collateral flow means you have a blockage, and then there's another artery that's sort of helped bypass it. Our body is very smart. The only reason that legs and toes and limbs survive with 100% blockages is because usually there's another artery that's sort of taken over. And it helps, but at the end of the day, in that particular patient that I'm referring to, you can do all the medical therapy in the world, but they're not going to get better. That blockage will not get better unless you go in there and fix it. So it just kind of depends on the degree of blockage we're talking about.
Mm-hmm. Patient to patient.
For sure. Yeah. So an exercise therapy program, it does work and it helps build collaterals. But at the end of the day, in my humble opinion, it's usually not enough to give the patient symptomatic relief.